Okay, I think I'll go ahead and start. For those of you that don't know me, my name's Shawn Milligan. I'm in the pulmonary section based at the VA hospital primarily. And although we've heard a lot about bad viruses lately in the news, especially Ebola, but also dengue and other viruses, it's also important to remember influenza because it's with us every year and causes, at least in the United States, a lot more morbidity and mortality than some of the other viruses have, at least to this point. So I haven't heard of grand rounds about influenza in a while, so I thought it might be worth reviewing the topic today as we approach influenza season. I don't have any disclosures or conflicts. I don't have any interest with any pharmaceutical companies or vaccine manufacturers. So we'll start by talking a little bit about the biology of influenza because I think that'll help you understand a little bit more about why we use certain vaccines and use certain types of treatment, and also understand about epidemics and pandemics. I'll talk a little bit about the clinical aspects of influenza, and then also about treatment with medications and also vaccines. And in doing this, I'm going to try to give a bit of an overview, but also emphasize certain new points and maybe points of controversy as we go along. So just a little bit about the virus itself. It's an RNA virus. And what's interesting about this, it will be very relevant as we proceed, is it's known as a segmented RNA virus. So these little bars here correspond to the different segments of RNA. And of course, they end up making different viral proteins. On the surface, we have different receptors, especially for the hemagglutinin and Neuraminidase. So with A and B, there are 8 genes, and they make 10 and 11 proteins that are important to the virus. Now, I know you're familiar with hemagglutinin and Neuraminidase. They're particularly important clinically. The hemagglutinin, there are different types, 16 different types, although in humans there's primarily 3 types that are most common in pathogenesis. But they're important because it allows the virus to attach to the host cell via certain receptors and fused in with the cell wall. The Neuraminidase comes in at the other end when the cell is trying to bud off and leave the cell to spread to other susceptible hosts. And what it does is then cleave the sialic acid so it can release the virus from the cell. Now there's actually 3 types of influenza, A, B, and also C, although we don't think too much about C. The naming might be a little bit confusing, so this just illustrates that. First we start out with the type of virus, A, B, or C. The place of isolation, in this case California. If there's a strain, that's the next number. The year of isolation, and then the subtype. B doesn't have subtypes, but A does, so we may classify that H1N1 or H5N3 or whatever. Now, as I said, there's 3 types of virus, but there are important differences. All the viruses can undergo what's called antigenic drift, and I'll define that a bit more in a minute. But that allows us the virus to change a little bit from season to season, and may be responsible for epidemics that occur periodically. However, only A has larger antigenic changes known as an antigenic shift, and this allows for pandemics to occur. So all the pandemics that we're familiar with, like the swine flu pandemic, was from an A virus. C virus is more like a mild upper respiratory infection. Doesn't cause major epidemics and not pandemics, so we don't really discuss C very much from a clinical standpoint. Now, epidemics, there is flu that occurs every year in the northern hemisphere and the southern hemisphere, but periodically, if there are more changes in the virus that have accumulated over time, then there may be a larger population that's susceptible, and that can lead to an epidemic. More people are affected, perhaps somewhat sicker than a prior season. But still, it's usually confined to one location at a time. So it might be in the northern hemisphere, it might pass to Europe, Asia, someplace else, but it's gradually circulating the globe, lasting a few months at a time before it subsides. Attack rates, the percent of people getting the flu may range from 20% up to 50% in a bad case. However, a pandemic is result of a major change in the virus, and that can gradually accelerate to the point of involving multiple parts of the world at the same time. The World Health Organization has different zones, and so many zones, North and South America, Asia, Africa, may all be affected at the same time or nearly the same time. Generally, there are higher attack rates, closer to 50% because it's a more virulent virus. And you may have several waves, and they may even persist over a few years. You may have early waves for a year or two, then a larger one, and then it may diminish for another year or two over time. Also, it can sometimes occur outside the usual season. We think of flu as a winter virus, which generally it is, but in pandemics it can occur at other times as well. Now, just a bit about morbidity and mortality. This is United States data at the top. It's felt to represent about 23,000 excess deaths a year, but there's quite a range, some lesser, some greater, depending on the virulence of the virus for that year. Possibly explaining about 200,000 excess hospitalizations a year. During the last pandemic in 2009, it's hard to get exact numbers, but from modeling studies, it's been felt that there were at least a couple of 100,000 respiratory deaths in excess worldwide during that pandemic outbreak. This just shows some differences between an epidemic and a pandemic. These are deaths from pneumonia, which is one of the worst and most frequent severe complications from influenza. And what you can see along the bottom here, we have the age distribution. And the black and white bars represent typical seasonal influenza. And so what you can see as far as respiratory deaths from pneumonia are quite high in the elderly, 75, 80 years old, and also the very young, younger than 4 years old. That's typical for seasonal influenza. But in the pandemic year, this reddish-brown bars, we can see that more of the pneumonia deaths, and these were deaths, not just cases of pneumonia, occurred in younger people. So this is 20 to maybe 40, 45 year age group. That's sometimes another characteristic of pandemics, is that the virus attack rate is higher and more severe in the young, and so that's also alarming. Now, one final word about pandemics. Pandemics is what we fear the most. We've all, experienced influenza outbreaks, sometimes epidemics, but the pandemic ones, as I've said, are the ones that are most severe and most to be feared. A lot of people have studied those, but unfortunately, at this time, it's really impossible to predict when a flu season develops or it's just beginning to occur. Is this going to be a pandemic or not? Sometimes there's maybe early predictors, but these were just a couple of quotations that I thought exemplified that. Every pandemic emergence seems to be a law in itself, and another one that's I like is the certainty of uncertainty is the only certainty or the only known. So at this time, this has implications for public health. Having enough antibiotics, enough fluoral drugs, masks, and other things to deal with pandemics ahead of time, because you really never know from one year to the next when these might be needed. Now, where does the flu come from? And we've heard about swine flu, avian flu. What does all that mean, and how do we relate that to humans? So I'll just have a few slides to review that area. Influenza is really naturally an infection of birds, specifically birds such as ducks and geese, wild migratory birds. And in some of those birds, the virus may be asymptomatic. In some cases, they may have just a mild infection, occasionally more severe infection. But that's the natural host, the natural reservoir for the virus. However, when other birds are in contact, for example, domestic chicken, geese, or other types of birds, they can become infected as well. And then moreover, mammals, including humans, as well as birds, dogs, swine, seals, they can become infected as well. So that's the relevance of the different animals. This slide just shows information about the bird and the importance of migration. For example, ducks, when they migrate from the wintering areas, they stop over at different sites where they nest and they molt. So this might be in northern United States or Canada. And then you have areas where they are as they migrate down south for the winter. So you know ducks are really migrating over thousands of miles. And of course, when they're doing that, they're coming in contact with a lot of other animals. Important to us is when they're in the wintering area, they may be more in contact with domestic ducks, other fowl, humans, pigs, etc. And this is where transmission can occur. So it's bad enough that influenza can be pretty easily transmitted as a respiratory virus, but then you have birds that are flying thousands of miles, spreading it, you know, from northern Canada to the United States, or from Asia to Russia and then to Europe, etc. Now, this is getting back to the concept of antigenic variation that I talked about. You can have variation, and that will cause a new virus, and you may have an outbreak, especially if people don't have much immunity. So if you haven't experienced that virus before, didn't have a vaccination, then possibly with some viruses you may have an epidemic if there's enough change from the previous antigen population. Now, antigenic drift, as I mentioned before, at the top, that involves minor changes. And since this is an RNA virus, there's constant mutations, especially in RNA viruses. And some of those may stick and lead to more virulent viruses. But they're usually small changes that may take a few years to accumulate and be substantial. In contrast, antigenic shift is when you have big changes in the RNA, up to 30%. And when you think of 20 or 30% of the RNA changing rapidly, that's pretty phenomenal. But because that happens, that's when pandemics can occur. But how could you get a shift of 20 or 30% in the genetic material? Well, the explanation of that is something called resortment. As I mentioned before, we saw that the virus has these segments of RNA, these little bars here. So in this case, we have a human virus and a non-human virus. It might be from a bird, for example, but it's infecting the same cell. And when that happens, these RNA can mingle, and you can get what's called a resortant virus, whereas you can see by the colors, you have some from the non-human and some from the human virus together. So in what situation can this occur? This is not something that we usually think about for most infections, two different species of viruses infecting the same cell and having this commingling. Well, the way it happens in one case clearly is through pigs. And so when you think about swine flu or swine and the relation of influenza, this is one reason it's very important. We talked about birds as being the reservoir, wild birds passing the virus to domestic fowl, but they can also pass it to pigs. And it's pretty easy for pigs to contract virus from fowl and also from humans. And pigs can also pretty easily transmit the virus back to the humans. Some transfer can occur from birds as well. So the importance of the pig or the swine is that people have found that it's a good place for this resortment to occur, and when that happens, then that's a situation where a pandemic could result. And this is just a funny figure showing, how intimate this chicken is with the pig sitting on top of it, so you can kind of imagine how this process could take place. Now, you may have heard of wet markets, especially in Asia and China. And a wet market is where you have huge numbers of animals together in a large market, and people come there to buy their animals and take them home for food. But the animals are live. So here you see ducks and chickens together, and here you see chickens at the bottom cage, and these look like cats here, and these are what are called civet cats, which are in China and Asia. And all these species are known to contract influenza. So when you have this on a very large scale, you can see how a virus can transmit from one species to another. They could potentially transmit to humans. Resortment can take place. And that's why some epidemics come out of areas like this, although certainly viruses have been transmitted from pigs in the United States and other places too. It's not just Asia. But if you hear in the news about the killing of thousands of birds in China because an outbreak has started, then this will help you understand why that occurs. I'll just go over this briefly. This just illustrates the complexity of some of the pandemics. And this illustration here was the 1918 pandemic, which was so severe, and it was felt to mainly come from an avian gene pool, birds that adapted to humans, and it caused that pandemic. Just for sake of time, I'm going to skip over to the swine flu, which was this virus over here, the pandemic H1N1, and its origin was more complex. It originally arose from this virus derived from the 1918, although there were combinations with other viruses along the way. Also from a triple resortant swine virus, and then a European swine virus. And so you see all these colors here representing different segments of DNA from different species. Basically, it was from two different types of swine flu, a human flu and a bird flu. So it was a quadruple reassortment causing the 2009 pandemic. You hear sometimes about other outbreaks. The H7N9 is a new virus that's been described recently in Asia, especially China, and you can see it's from 4 different types of birds. It doesn't easily transmit from human to human, but when a human catches it, the mortality has been pretty high, about 25%. So hopefully this won't adapt so it can spread more easily, because it may be a type of virus that could result in a future pandemic. Okay, we'll just talk a moment about influenza syndromes. Influenza itself is often more of an upper respiratory virus. People have cough, fever, chills. They're pretty miserable, but they get over it within a few days. But what we are concerned about more is that sometimes people can progress into the lower respiratory system and actually get a viral pneumonia. Or another thing that can happen is the patient may start to recover from the influenza, but after a few days they can relapse with a bacterial pneumonia, and then the bacterial pneumonia becomes a predominant factor in causing illness. And sometimes in the mixed variety, at the bottom it's just a continuous progression, and there's no clear distinction between the viral process going into the bacterial pneumonia. This just shows a little bit about the pathogenesis, how the virus invades the cell, it replicates the RNA, it's released because of Neuraminidase is cleaving the cell from the viral particle. And as that occurs, you can have damage and inflammation. So on the left, we're just seeing inflammatory cells within the area below the basement membrane, the respiratory epithelium. The dark areas here represent viral particles with an immunostain. This is from the swine flu epidemic in 2009. Here you see fibrin deposits distorting the alveoli, so you don't see any good alveolar structure left. This is a case of viral pneumonia. And here this is a hemorrhagic case where there's obviously a lot of red cells within the lung. As I said, pneumonia can occur in some cases because the normal respiratory epithelium is damaged by the virus. You can lose the cilia. Cells are damaged, so bacteria can contact the basal level. Even the basal cells can be damaged, so you have free basement membrane. All that allows adherence and colonization by bacteria that can result in pneumonia. Again, this is from the 2009 pandemic. This is just a gram stain here on the right of gram-positive cocci. Neutrophilic infiltrate. This would be representative of any type of pneumonia. And this was an immunostain for group A strep. So the little dots that you see represent strep, corresponding to what you saw on the gram stain. This is staph pneumonia. Here again, a immunostain for staph. And what you see here, rather than fibrin, is just a big cavity. And that's because this is an area of necrosis of the lung as a result of the staph. This is a few radiographs. Here's a viral pneumonia. It tends to be kind of a patchy pneumonia, so you see a little infiltrate here and some here, not so much on the other side, perhaps down at the left lower lobe. This is the bacterial pneumonia. You see air bronchograms here very nicely. Also a little bit on the left side as well. And then here's staph pneumonia. As many of you know, it often causes cavitation, can be really a terrible infection. And that's best seen on the CAT scan, where you can see multiple cavities throughout all areas of the lung. This patient was intubated because of the respiratory distress. Now, bacterial pneumonia is a serious complicating factor of pneumonia. And from the 2009 pandemic, this was a study in United States ICUs of 685 patients. And what they found, and these are ICU patients, but about a third of them had bacterial co-infections, primarily pneumonia. And you can see the pathogens, as we've talked about, staph, especially MRSA, strep pneumonia, and also group A strep. And the patients that had pneumonia had higher rates of mortality, more shock, and more days on the ventilator than the persons that did not have pneumonia, not surprisingly. But again, 30% mortality, that's pretty high. And in the pandemic 2009 outbreak, many of these were young to middle-aged people. They weren't necessarily the old folks that you think about in some other epidemics. As I talked about, these are the usual pathogens: staph, strep pneumonia. Obviously, if someone's been in the hospital a few days before they develop the pneumonia, they might be at risk for hospital pathogens such as gram-negatives, including Pseudomonas. And interestingly, there's not as much about this, but some studies, when they've looked at it, have found other viruses as well, other influenza viruses, other respiratory viruses, depending on where you live, perhaps even dengue. So it's unknown just how much this plays into the pathogenesis of the disease. Now, just a word about testing for influenza. You're probably familiar with the rapid influenza tests known as RIDTs. And in the United States, there's a dozen or more different tests that are approved. These are the little swabs from the nose or the nasopharynx to rapidly make a diagnosis. The important thing about this is that the sensitivity is only about 40 to 70%. It's a little higher in kids. And what that means is that if you have a negative test, obviously it doesn't necessarily exclude influenza. So if it's flu season, and you know lots of people are coming down with the flu, and it's known clearly that flu is in the community, and you do a rapid test, your patient has an influenza-like illness, and you're considering therapy, you don't ever want to withhold therapy because you had a negative rapid test. If it's really important to make a concrete diagnosis, you'd probably want to use the PCR test. Probably in most people that's not necessary. If they had an influenza illness and everybody around has influenza, then you could assume they probably have influenza too. But if necessary, the PCR would be the way to make a confirmatory diagnosis with much higher sensitivity. Sometimes neither test is good in the upper respiratory system. Perhaps it's been several days later and the person's having more of a pneumonia, maybe more of an influenza pneumonia. And this was just a small study showing that BAL, these are intubated patients, was better than upper respiratory samples collected at the same time. And even here, some of the rapid tests didn't perform as well, even though all of the BALs were positive for influenza by PCR. Now, as far as public health and safety of yourself and other patients, you'd like to know something about viral shedding. And as is true for many viruses, patients can actually start shedding a day or so before symptoms develop, and then maybe a week or 10 days afterwards. Children perhaps shed a little bit longer, but what's especially important to know is that people that are severely ill or immunocompromised patients may shed much longer. So a patient on a ventilator may shed for several weeks, possibly that's because they're somewhat immunocompromised from their illness. And a patient that's had chemotherapy from cancer or some other immunosuppressive disease, they can shed for weeks, sometimes even months. In fact, they can shed for sometimes weeks even though they're on continuous treatment, because obviously you need an intact immune system to eliminate the virus. So if you're working with this type of patient, Even though the time is progressed on where you wouldn't think they would be contagious, you still want to use precautions, infectious precautions in dealing with those patients. Just other things about infection control that you all know. You want to use droplet precautions with a mask. There's the generally applied 6-foot rule as far as close contact, but some people feel that, you know, someone's coughing, you may well spread influenza past 6 months, so 6 feet. So there's nothing magic about a 6-foot barrier. If someone's coughing vigorously and you have the flu, then, you know, I would want to be cautious in any circumstance. Hand hygiene, very important. Appropriate contact precautions, changing gloves and gown with each encounter. If your patient has to go down for a CAT scan or something, you want to make sure they've got a mask on themselves. Different studies have looked at the viability of influenza on different fomites, but it may be anywhere from 2 to 8 hours, perhaps even longer. You know, obviously if you're in the room or where a flu patient has been, then any surface is a possible place where the virus could be and obtained. So keep that in mind as well. Of course, we're all pretty aware of this with all the Ebola outbreaks. Certainly influenza is not Ebola, but it is a virus that could be probably transmitted through fomites, so it's worth reiterating this. Now, what about masks? In the 2009 outbreak, there actually were shortages of masks in some centers. A lot of people were using the N95 mask because they felt it was better. And there was such a rush on the mask in the whole United States that the manufacturers just didn't have enough, and you just couldn't order it anywhere. There just, you know, were gaps someplace. So this was an interesting study, one of the few that I found on this subject, you know, which is really better, what do you need? And this was a study from Canada at several hospitals where they had a group of nurses, and they were randomly assigned to an N95 or a surgical mask, and then they looked at, you know, which nurses actually had influenza by PCR. This was during a flu season. And the attack rate was pretty high, about 23%. And what they found was when they compared the mask, the surgical mask was non-inferior. So that might be kind of a surprise. You know, they postulated, well, maybe the nurses didn't always wear it, or maybe they didn't wear it right, or maybe they really just is not inferior. But from this one randomized study, it didn't seem that there was a great difference. You know, sometimes you don't have an N95, so you know, you can take some comfort in this, and that a surgical mask would be helpful. I think the bottom point is certainly something to keep in mind, though. If a patient is coughing a lot, if they're having to be intubated, if you were doing a bronchoscopy or something else, where they're going to be potentially expressing a lot of virus, then you'd want to take probably the better mask, and that's the N95, because the surgical mask really isn't tight enough to, you know, exclude the virus from coming around the edges or even through the mask itself. What about a face shield? You know, we don't generally think about virus being transmitted through the eyes, through the conjunctiva, and there's even less information about this. But the eye actually does have sialic acid receptors, although they're different than respiratory sialic acid receptors. But there's been some limited evidence suggesting that the flu virus might be able to bind to that. And then just a small study looking at attenuated flu vaccine virus, which is a live virus. When that was aerosolized into people's eyes, it could be found later on in nasal washings. You could do a nasal irrigation and actually grow the virus. So it may have just been transmitting through the lacrimal duct to the nose. And of course, if it did that, it could certainly cause illness if it wasn't an experimental virus. So again, I don't know that we all have to go around with face shields, but certainly if you're doing a high-risk procedure, again, like an intubation, ICU, or something like that, then it's something worth considering. Now we'll go on to talk about therapy, neuraminidase therapy. And I've shown illustration a little bit like this before, but this just shows a virus getting ready to bud off. Here you have the RNA and the membrane being formed in the receptors. And what happens is it buds out. It's still attached to the cell through this sialic acid receptor. So the neuraminidase of the virus is important. It's there around the cell surface to cleave this off, and that allows you to have release of virons and can continue the process. So a neuraminidase inhibitor is just blocking this step. Here it's illustrated with these little caps and they're just shown on the top of the neuraminidase. And so what that does is it prevents it from cleaving the oxalic acid, and the virus is held on the surface of the cell, and then you can't get further propagation. So that's the principle of the neuraminidase therapy. Now, the oxalic acid is illustrated here at the left, and the zanamivir and oseltamivir are two of the main drugs that we use. And you can see, you don't have to be a scientist to see how similar the structure is to actual oxalic acid. So that's how they're working, is they're mimicking this, and they're able to stick to the neuraminidase. And here's some experimental neuraminidase inhibitors with similar structure. Just a brief overview of the therapy themselves, if you haven't used this a lot. Oseltamivir is an oral drug. It's given for 5 days. It's pretty safe. It can be used down to children 2 weeks of age. So that's good. Side effects mainly are GI, nausea, and vomiting. Some people have quite a problem with that, but otherwise relatively safe. The other drug, which many of us haven't used, is zanamivir. And it's not that the drug isn't good, it's that it has to be delivered through this inhaler, which is a little bit cumbersome. People have to take 2 puffs twice a day, again for 5 days. And the problem here is that there's potential for bronchospasm in people that have asthma or COPD. And since a lot of people with respiratory problems have that, then you tend to shy away from using it in that population. Also, some people can get other nasal symptoms, cough, may just be nonspecific irritation from the drug. And this just illustrates the inhaler. It's actually a little blister pack with 4 doses. So you have to take 1 puff and then the other in the morning and then another puff and then the second one in the evening. The little blister pack goes in this little wheel device, and the little needle sticks in to release it. So if you've never seen it, that's the disc inhaler. Now, the big thing about treatment is that in the spring, the Cochrane Review Group released a big study on the effectiveness of neuraminidase inhibitors. What they did is they included 46 randomized controlled trials. They didn't include any observational studies. The other really big thing that they did was they included clinical study reports from the drug companies. And evidently they decided this was going to be a test case in trying to get the actual clinical study reports, which had never been done in one of their reviews before. And as was reported in one of the medical journals, they said it was a 3.5-year battle to get it. The drug companies didn't easily relinquish this. They didn't want to, but they made a big thing of it, and it was in the press, and they pressured them, and finally they were able to get this information. So this is something that's sort of never been done, but now there's a precedence. Perhaps we'll have this more and more for reviews and for studies so we can fully analyze the data. Now what they found wasn't very pretty. They said that about half of the oseltamivir and most of the zanamivir studies had a high risk of selection bias. As far as treatment, which really tends to jeopardize all of the data after that. The other thing they reported is that the effectiveness of the drugs for ordinary seasonal influenza wasn't that great, decreasing symptoms by perhaps 17 hours in adults, 29 or so hours in children. There was no effect on hospitalization in children. And as far as complications, they went to look at pneumonia and other complications. And the definitions were so poor. For example, people didn't necessarily need an x-ray. It was just self-report. Do you have bronchitis, pneumonia, otitis? It wasn't a rigorous criteria that they really couldn't make any conclusion about that at all. So this received a lot of bad press. People began to think, well, are these drugs worthwhile at all? And some groups criticized countries for stockpiling the drugs for use in epidemics or pandemics, and certainly it created a lot of publicity. Now, for sake of time, I'll just go over this kind of quickly, because there are other points about this that are important to know. But because of that study, some people just felt that I'm not going to use this if people have influenza, but that might be taking it a bit too far. So as far as the limitations and some of the important points, the part about the decrease in symptoms for less than 24 hours, that's been known for a long time since the original studies. That was not something new. Importantly, I think most importantly, was that the trials were originally done a number of years ago to obtain approval for the drugs to be used in seasonal influenza. In other words, pretty healthy people, seasonal influenza, mild disease, do they have some effect so we can get approval for the drug? So that was the premise of the studies. They weren't powered or designed to look for hospitalization, ICU admissions, or death, because a lot of that is pretty uncommon with flu, especially death, unless you have pandemics. There aren't any randomized trials for hospitalized patients. And the people that are more at risk for complications, COPD, cardiac patients, diabetes, et cetera, they're not included in the randomized trials either. So that's another reason that they couldn't make too much comment about that. So given that information, there are some other studies looking at those types of patient populations. I'll just give one as an illustration for sake of time. This was a meta-analysis published this spring. It was nearly 80 studies, 29,000 patients. This was all the pandemic flu of 2009, which is, as you know, is a particularly bad year. And they looked at hospitalized patients worldwide. So these weren't the typical outpatients. These were people that were sick enough to be in the hospital. And what they found was that there was a benefit from treatment. Treatment within 2 days was associated with a reduction in mortality risk. Early treatment versus no treatment, reduction in mortality. In children, there wasn't a difference. And the more you delayed up to 5 days, there was also a difference. So even though this wasn't a randomized controlled trial, this supported the use of the drug in sicker patients. So what is the current recommendation? I looked this up just in about a week ago from the CDC website just to make sure it was updated. And also in the spring, the Infectious Disease Society put out a statement in response to the Cochrane review, and recommendations are pretty similar. And this is a summary of that. They do recommend neuraminidase treatment as soon as possible for people that have influenza or even suspect have influenza if they're hospitalized or if you have progressive or severe complicated illness. Now those are kind of broad categories, and that's probably best. They're not using vital signs or x-rays or other things, because you want to start treatment soon. You don't want to wait for other things. So if someone's sick enough to be in a hospital or has progressive disease, they recommend treatment. Now for outpatients, they recommend treatment for people that are at risk for influenza complications. So who would be the people at risk for complications? I won't read all of these to you, but it's the groups that you would naturally think about. People at the extremes of age because their immune system isn't as good. In the 2009 pandemic, women who were pregnant were somewhat disproportionately affected by the virus. There are a lot of severe disease in those people. Also in the 2009 epidemic, it was noted that people that were morbidly obese had a lot of severe disease, even people that were middle-aged and otherwise fairly healthy. Of course, patients that are immunocompromised, those with the usual medical comorbidities, nursing home residents, and others. So these are the people at risk for complications if they develop the flu. So these people, as well as ones that are hospitalized with progressive disease, those are the ones that we should still consider for neuraminidase therapy, according to the CDC, and I would tend to agree with that. I would be comfortable with that. Now what about the other group? This is probably the larger group of people, many of the students that we have here or house staff. You'd be in this category. So what do they say here? Treatment could be considered based on clinical judgment if you have uncomplicated disease and it's not progressing to more severe state, especially if you can begin within 48 hours. They also say people with uncomplicated disease probably don't need treatment. And if you're already starting to recover, you for sure don't need treatment. So there it's optional. We know from the studies that it probably doesn't do much in a healthy person. So you probably really don't need it at all. They're not prohibiting it, but you know, that's based on your judgment and your physician of whether you would want to use that. But that's much different, obviously, than the other group of patients. Just a little bit about high-dose oseltamivir. Sometimes this comes up in patients that have severe disease in the ICU, for example. There's not a lot about that, but there's been a couple of recent studies. This one was done in a couple of hospitals in Hong Kong over 2 seasons. With 2 different types of virus. One was the pandemic virus, and they gave the standard dose or a double dose. And basically they didn't find any difference in influenza A outcome as far as clinical response, the rate at which the RNA declined, culture negativity for the virus, et cetera. It didn't differ. Now, a limitation of this is they were hospitalized patients, were very few were in the ICU. So you might not be able to apply this to critically ill patients in the ICU. For influenza B, they did find that the RNA decay rate was faster. Whether that makes a big difference clinically, I'm not sure. This is another study done in several Asian countries, 300 patients, mostly children, a variety of viruses. H5N1 is one we don't see here much, which is good because it's highly virulent. These are the more typical viruses. But they also use standard dose or higher dose based on weight, et cetera, as you would for kids because so many of them were children. And they also didn't find any meaningful difference. As far as the negative viral RNA by PCR, that was the main endpoint. There wasn't a significant difference there. As far as clinical failure, there was no significant difference, or fatality rate. Although, in general, there's a low fatality rate. The H5N1, that is a quite virulent virus. It's one that's not transmitted easily from human to human, so it's more localized in Asia. But there was no difference there either. So from what limited information, we can't make a clear statement about this, but nothing real positive about using higher dose therapy at this time. Now, in contrast to that, there is something important about late treatment. And I think this is important because some people feel that, well, if it's been beyond 2 days, we all know that 40-hour rule, it's better to be treated early. If you're healthy and it's been beyond 2 days, you probably don't need treatment at all. Some people may take that a little too far and just say, well, if it's been 3 days, no matter what, I'm not going to treat you. So this study kind of got to that question. This was a study done by the CDC in the state of California in ICU patients over this flu season. So they had about 1,900 patients, and most of them did get treatment, but 10% for one reason or another did not get Neuraminidase treatment. As you can see here, these were mostly a younger age group, although many had comorbidities. About 2/3 or more were on a ventilator, had ARDS, so these are very sick patients. 26% mortality rate. So what did they find? Well, this is a graph of time to treatment, and this is the people that never got treated, the 10%. And their mortality rate, or this is the percentile who survived, was 58%. So, there was a higher mortality. And these are the people that started getting treatment on day 0, was 88%. And what they found is up to day 5, this was 71% that survived. So this is declining, the group that survived, the farther you delayed it. But up to day 5, this was still more significant than people who were never treated at all. So this is just one study, but it suggests, in at least people that are critically ill, if it's been beyond 2 days, because sometimes people just don't come in until they're ready to go straight to the ICU. It's probably not wise to withhold treatment. It's a pretty safe drug, and this one study suggested at least up to 5 days. Now, whether the real number will be 4 days, 7 days, I don't know. If it's that type of patient, I'd probably be pretty liberal about it. But I don't think we should be too dogmatic about the 48-hour rule in people that are very sick. I won't mention too much about this because I'm kind of running out of time. But luckily, we don't have a lot of problem with oseltamivir-resistant virus. This is the drug that we use most often because it's easy and pretty safe. But it does circulate when people have done studies, although it hasn't had a big problem as far as expanding to the larger population and becoming a bigger problem. That's not to say it couldn't happen at some point, but we've been lucky so far in avoiding that problem. If you did find this or suspect it, the mutation that's most common, this one here, luckily doesn't affect the utility of zanamivir. And so if it was a sick patient with resistant virus, it would be recommended that you use IV zanamivir. That's not commercially available, but it can be obtained through compassionate usage. And so you'd want to consider possibly getting IV zanamivir for use in these patients. Now lastly, I'll talk a little bit about influenza vaccination. This could be a whole grand rounds in itself. vaccination is a pretty complex topic, but I'll just try to make a few points and give you a couple of recent studies about vaccination. Vaccination is based on the antibodies to mainly the hemagglutinin. And what's important to realize is the vaccines produce what's called non-sterilizing immunity. That means that if you were vaccinated and you came in contact with the virus, it doesn't mean you wouldn't become ill at all or you wouldn't propagate the virus, but it would lessen the propagation, and so you'd be less likely to be sick, or especially less likely to be severely ill. So it's not a perfect vaccine from that standpoint. Now, as I've implied before, there's a definite seasonal occurrence of flu virus. Where we live, we're just beginning the season, November through April. In the southern hemisphere, it's just the opposite. So at all times, flu virus is circulating through the globe. In the tropics, it can occur at any time. But vaccines that we've had in the past were based on production in eggs, which requires about 6 months or so. So the bad thing about that is the choices for vaccination for the strains had to be made on the prior season, what was happening a few months ago, because there's such a long lag time in producing that. And so that's why sometimes vaccine efficacy can vary from season to season. This was a recent review from the CDC looking at this recent season for flu, and they found this effectiveness for the flu vaccine. And 60% is not unusual. Some seasons will be 70, 80%, but it's rarely more than that, and this is often more typical. Now, what's striking here is that by age group, you can see once you get to be older and your immunity is not quite so good, the effectiveness really drops off quite a lot. That was for the H3N2 that was looked at. I just skipped that for sake of time. Now, the flu vaccine that's available this year is actually the same as last year. It's 2 A strains, an H1N1, H3N2, and a B virus for trivalent, and a quadrivalent vaccine has another B virus, because it's found that nowadays A's and B's can circulate together, and more than there can be 2 or 3 circulating at the same time. Now, recently, for various reasons, there have been different vaccines developed. There's a couple that are developed in other systems, for example, mammalian cell culture and recombinant DNA. And one good thing about these is the production time is much less. I don't know exactly what it is, but it's not the 6 months that are found in egg-based systems. So that might allow more rapid ramp-up of vaccines in response to severe disease, possibly pandemic. That's not been tested exactly, but there might be the potential for that. Also, with the flu block, the recombinant, there's no egg protein, so if the patient is allergic to eggs, that would be the safest choice. With the mammalian system, it's not made in eggs, but it has a little bit of egg albumin, so if somebody had severe reaction, anaphylaxis or something, you would want to avoid Flusilax. The intradermal vaccination is made with the idea that you can use much less antigen. It's injected into the dermis where you have dendritic cells and other immune cells. You may be able to get a little bit better immune response with a lower dose. And if you had a big outbreak or pandemic, you might just not have enough antigen prepared in time to vaccinate millions and millions of people. So the intradermal vaccine theoretically might allow you to get by with lower dose and still be effective. Now, the flu mist, I don't have any personal experience with that, but it's an attenuated virus. It's a live virus. It can be used in children up to age 49. In general, it's been more effective than the inactivated in children, but I understand that last year and this year, at least one of the strains didn't work well at all, so that's going to have to be revisited. I'll ask for comments from the audience, because I know there's some people here that would know more about that in kids than I. Now, there are some contraindications, pregnancy, immunocompromised patients. One thing you might not think about is if you work with a lot of immunocompromised patients, you're an oncologist, for example, you might not want to get this, because since it is live attenuated, it wouldn't bother you, but it might be able to be passed to your patient. So that would be something to think about. Now, At the end, I'll just talk a little bit about a couple of the new studies. These have just come out in the last couple of months. One was the high dose versus standard dose in older adults. I showed you how sometimes it's much less efficacious in older people. So this was studied in people that were older, and that's because, as we said, the antibody response is lower and many of the deaths occur in older people. So this was 15 micrograms standard dose versus 60 micrograms, studied at multiple centers in the United States and Canada, nearly 32,000 patients. And this was the group that developed influenza, 1.9% standard dose, 1.4% high dose. That doesn't seem like much, but it was a significant protection. And they didn't look at people that weren't vaccinated. They just looked at the two vaccinated groups. But extrapolating, they calculated the absolute efficacy to be about 60%. So that's not hard and fast, but that would be pretty typical of many vaccines in adults. Also, the geometric mean titers were higher in the higher dose. So it seems like it might be better. I'm sure this will be studied a lot more, but it's promising for people that are older and may not have as good an immune response. Now, this was another study that was just published in the last month or two, and this looks at influenza vaccination in pregnancy. I don't think I had a specific slide for this, but it's known that influenza vaccine is safe in pregnancy, any trimester, no higher rate of premature labor, or premature birth, or adverse outcomes than not. And so it's recommended in women who are pregnant. This is one recent study looking at that. It was actually two groups of patients, one HIV negative, one HIV positive in South Africa. And the people that developed, this was the trivalent inactivated vaccine. The people that were vaccinated had a lower attack rate than ones that were not, and the effectiveness was about 50%. And furthermore, looking at the infants, of course, they had antibodies from the mom. It was effective in infants as well. In the HIV group, it was also effective in the women, 7% opposed to 17%. But unfortunately, it wasn't as effective in their infants, the HIV positive mothers. So that was not statistically significant there. So this was new information, especially about infants of mothers. I think for sake of time, I'm just going to skip chemoprophylaxis, and that's not something we do too often. But I'll just leave a couple of minutes for questions if anybody has them, or if not, thanks for your attention. Dr. Wilson, did you want to comment on the live vaccine in the children? Is that true about the less effectiveness recently? Is that something you're familiar with? Or? Have you all heard about that?
I just know what Dr. Booking told us last week.
Okay.
They presented to the ACI the data from the last season. After the first season, they had enough H1, 2009 H1N1 to actually study vaccine effectiveness in children. What they found was the live inactivated was not effective at all in kids between 6 months to 5 years. The live is more active for the age 3 and 2.
Okay.
And so it doesn't seem to be that it's related to the cold chain. They think it may be related to the strain that was picked for vaccine manufacturing. So they're kind of debating what to do for the next influenza season, because right now there's preferential recommendation for children to get the live vaccine starting next year.
Okay.
So they're going to revisit that.
Okay. Any other questions or comments? All right, well, thank you very much.